Hello, everyone. Thank you for tuning in to this webinar series, the Med Safety Exchange, a joint venture by the Institute for Safe Medication Practices Canada, ISMP Canada, and the Canadian Patient Safety Institute, CPSI. So just a few housekeeping items. The webinar will be recorded, so those that aren't available at this time do still have access. We have all the lines muted, and we encourage any questions or comments to be typed to us in the chat box, and then we'll read them out loud at the end of the webinar during the discussion. I'm sure most of you are aware, but for those who may be joining us for the first time, the purpose of this webinar series is to provide another modality and platform whereby we can share and learn from one another to minimize the recurrence of med incidents and optimize med safety in all care sites. Every webinar will have roughly the same structure, but with different content. So this month, we'll have one med incident analysis regarding a morphine overdose due to limitations with pump programming, and a description of a med safety initiative around insulin safety. This will be followed by the observatory for a med safety update, and then finish up with the discussion period where we read out your comments and allow the speakers to elaborate. Anonymity is a choice for all those involved in the webinar, so I'll only introduce speakers briefly, and they can choose to share as much or as little as they'd like about themselves and or their practice site. I'd like to invite the first speaker to discuss an incident analysis involving a morphine overdose due to limitations with pump programming.
Good afternoon, everyone, or good morning, depending on where you are in the country that you're listening from. First, I'd like to thank Ambika and her team at ISMP for contacting me and allowing me to share this incident and our learnings from it. Just a brief description. Sorry, technical difficulties. Just a brief description of our facility. We're a 500-plus bed facility across 2 campuses in Ontario. We're one of the largest community hospitals in Ontario, and we serve a population of about 400,000 people. We are a regional provider of advanced care, including stroke patients, cardiac care, renal dialysis, complex trauma, neurosurgery, intensive care, acute mental health. We do have family birthing, neonatal, pediatric, as well as regional cancer services amongst our general and surgical services. For the case, we have a 73-year-old patient who was made comfort care. There was an order written for a morphine drip at a rate of 1 to 5 milligrams per hour, discontinuing all other blood work, x-rays, and other medications. We received the order in our pharmacy department, and we processed it with our standard morphine of 100 milligram in a 100 ml bag, which was sent to the unit. The morphine bag was received on the unit and attached to our smart pumps. The pump was programmed, identifying a starting dose of 2 milligrams and a total bag volume of 100 milliliters. The pump was double-checked at the time of initiation. The pump alarmed after 30 minutes, and when the nurse went to the patient, there was no medication remaining in the bag. The physician was immediately notified, family meeting was held, and the family was made aware of the error. Oxygen was removed from the patient upon family request, and the patient subsequently died. So our incident review team received an alert immediately with regards to the incident, and the pump was taken out of circulation so that we could do some testing on it. So we held a root cause analysis meeting within 24 hours. Actually, we held the meeting the following morning. We involved the nurses that were involved in the incident, and the programming process was walked through. Upon completion of our root cause analysis meeting, we held an organizational QSIPA meeting, the Quality Care Information Protection Act, that was held about a week later. So during our incident review process, when we looked at the pump, we had the nursing staff identify how they programmed the pump. So you'll see on the right-hand side is our morphine blank screen. When they programmed the pump, they programmed the 2 milligram dose, the volume to be infused at 100 mils. What was not identified at the time was the time on the bottom, which was a standard set of 30 minutes, because the choice that they made in the pump was for our intermittent dosing. So what we identified through the process was some contributing factors. We had limited pump programming options on the general care units. During our recent launch of the Smart Pump, we only built a morphine intermittent infusion option on our general care libraries. We did have a morphine infusion option in our critical care libraries, and during the vetting of the pump library with our multidisciplinary team when we were building our pump library, it was identified that morphine pumps were generally run on our critical care units and not in our general care floors. Previous orders for morphine drips, we came to find, were being run under the IV fluid setting. And since the nurses were accustomed to the continuous infusions, there was a confirmation bias during their programming. They did input the 2 milligrams, but that was an intended of a 2 milligram per hour rate for a continuous infusion, as opposed to a 2 milligram in total bag for intermittent bolus dosing. They did not notice the infusion time that was set to 30 minutes, again, a component of our intermittent dosing. Additional factors, there was no hard dose limit that was applied to our intermittent morphine drug library. The double check that was performed by the nurse was done at the same time as the initial programming and not independently, so again, biased. There were no defining monitoring parameters for morphine doses of less than 5 milligram per hour, so follow-up with the patient did not occur until the pump alarmed, signaling that the bag had been emptied. Some process improvements that were made from the QSIPA and the root cause analysis, identifying that morphine continuous, though not frequent on our general care areas, was something that could be done for our palliative patients. We did build into the infusion library an intermittent choice and an infusion choice. Along with those two choices, we built in additional clinical alert screens. So you'll see on the far left-hand page, we now have a standard infusion as well as an intermittent. When they choose the standard infusion, it identifies that it's for palliative care patients only, again, that it's a high alert medication and that an independent double check is recommended. When the intermittent infusion is chosen, it identifies to the programmer to confirm the admixture. So are they truly punching in a 2 milligram in 100 ml dose? Our multidisciplinary IV pump team began running compliance reports on our pumps, as well as auditing the pump. So we recognize the limitations of the data that's coming out of the pump. So even though our DERS mode, our drug library mode, is almost 100%, we recognize that IV fluid setting could be contributing to those measurements. So we did have some students going through our nursing care units and actually looking at the pump, looking at the drug that was running, as well as what was actually programmed. And we did find that the IV fluid setting was not being used on drugs. We did develop some standard work documents that could be reviewed at nursing unit safety huddles, which included smart pump programming, as well as the independent double check process. Utilizing our ISMP colleagues, we redistributed the ISMP safety bulletin, understanding human over-reliance on technology. Again, we wanted to promote the fact that even though we have smart pumps, we do have to take the time to really look at the settings that are being placed in those pumps and ensuring that the independent double check is being completed. That's my presentation. I don't know if there's any questions.
Thank you. So we'll actually have the questions saved for the end during our discussion period. But I do appreciate that thorough incident analysis with the inadvertent morphine overdose. It is another reminder to us that technology needs to have the appropriate processes, procedures, and training in place to support its use and to optimize patient care outcomes, because technology will have positive patient outcomes when used appropriately. So I'd now like to introduce the second speaker to describe the multidisciplinary approach that their team took to improve insulin safety in their practice setting.
Thanks, Ambika, and thank you to both ISMP and CPSI for inviting me here today to share one of our medication safety initiatives, a multidisciplinary approach to improving insulin safety. So my name is Nancy Louie. I'm a medication safety pharmacist, and I work for Alberta Health Services. And before I start describing our initiative, I thought it might be helpful to share a bit of an overview about our organization. Alberta Health Services, or AHS, was founded in 2008 and brought together 9 regional health authorities and 3 agencies, forming the largest health system in Canada. In terms of numbers, AHS employs over 100,000 people, serving 4.2 million Albertans in over 650 different facilities across the province. Within these facilities, we have almost 9,000 acute and subacute care beds. As well, AHS has 13 strategic clinical networks, or SCNs, which are comprised of a wide range of disciplines, including clinicians, researchers, policymakers, patients, and families. These SCNs focus on driving innovation and standardizing care. The reason I point this out is because one of the SCNs, the Diabetes, Obesity, and Nutrition SCN, played an important role in supporting the safety initiative. So we call it the DON SCN for short, and I'll expand more about that later in our presentation. So from a medication incident reporting standpoint, in AHS we have a single province-wide system for patient safety reporting. The Reporting and Learning System for Patient Safety, or RLS, is a voluntary system, and staff are encouraged to report hazards, close calls, and adverse events for the purposes of learning and improving patient safety. The review of RLS reports can help us identify trends and opportunities for improvement. Our medication quality and safety team has identified that over 1,000 insulin-related reports are entered in RLS annually. And further review of this data showed, not surprisingly, that the majority of events occur in the administration stage. And the most common problem types are wrong time, wrong dose, wrong drug or formulation, and wrong patient. Our data review, plus the fact that insulin is a high alert medication, helped our team determine that this was an area that could benefit from targeted safety strategies. And this work began late in 2013. Shortly thereafter, the DON SCN was assessing the current state of inpatient diabetes management in our province. And this included executing both patient and provider surveys. Their assessment helped to guide them towards the development of a multidisciplinary provincial initiative to improve and standardize how patients with diabetes are cared for within Alberta hospitals. It was at this point that pharmacy services became involved by identifying areas of risk related to insulin use that could be addressed within this broad initiative. And subsequently, our team took on the responsibility for 2 safety initiatives within this broad framework. This diagram shows the many components of this initiative, and apologies, I think it's a bit blurrier than I thought, so it might be hard to read the details. But I did want to point out a few of the key improvements within this initiative. Firstly, the ongoing spread and implementation of basal bolus insulin therapy, or BIBIT, provincially. As well, they looked at the standardizing of the safe management of DKA in the emergency department. Also looked at increasing nutritional support for diabetic patients, as well as standardizing the management of both insulin pumps and hyper and hypoglycemia in AHS. In terms of time frame, much of this work took place over the last couple of years and is still underway. As the previous slide showed, there were many different clinical departments involved in this initiative, and I wanted to share a quote that supports this multidisciplinary approach. Considering the complexity of improving insulin therapy in hospitals and lessons learned in previous efforts, organizations should approach insulin safety in a comprehensive and coordinated manner. The impact of comprehensive medication safety practices is substantially greater than the sum of its components. So in our experience, the coordinated efforts in this quality improvement initiative were really the key to its success. So switching gears now for the remainder of my presentation, I wanted to focus primarily on the pharmacy-related safety initiatives. The first initiative was to simplify and reduce the number of insulin products and formulations on our provincial drug formulary. This strategy would potentially reduce product confusion and reduce the frequency of wrong drug and wrong formulation errors. The second strategy was focused on patient-specific dispensing of insulin, a change from our historical practices of providing insulin as ward-stock multi-dose vials. Included in this transition was the switch to patient-specific disposable insulin pens at the majority of AHS sites. This strategy could potentially reduce the frequency of both wrong patient and wrong drug or formulation errors, as nursing staff would no longer need to select the correct insulin product from ward stock. During the planning stages of our Formulary Safety Initiative, extensive consultation occurred with the DO and SCN, and this included engagement with endocrinologists, diabetes educators, pharmacists, and patient advisors. Generally speaking, our provincial formulary decisions are based on evidence-informed reviews of drug efficacy, safety, fiscal sustainability, and they also take into account continuity of care and clinician and patient choice. To reach this formulary decision, a provincial review of the current state of insulin usage was completed, followed by consideration of all the available insulin products, sizes, and formats. Therapeutic interchanges, i.e. approved automatic substitutions, were put in place for specified non-formulary insulins. And ultimately, the goals of streamlining the formulary were to reduce duplication, standardize options, including formats, and limit product confusion. So as you can see, the original list of insulin products available in AHS was quite extensive. It's on the left here. And in the end, we settled on 8 products. This table shows the insulin products that we ended up with currently on the AHS formulary. And in addition to products, we also tried to streamline formats. In general, vial sizes are limited to 3 mL where available. And cartridges and refillable pens are not used due to the additional risk of error, such as putting the wrong cartridge in the wrong pen. So generally, pre-filled disposable pens are preferred. So once our formulary streamlining project was complete, we then turned our attention to our second safety initiative. Historically, most sites in AHS were supplying insulin as ward stock and multi-dose vials. So this initiative involved transitioning to patient-specific dispensing of insulin where possible. Generally speaking, short-stay units such as Emerge and day surgery were excluded, but sites were encouraged to make local decisions about which client service areas were best suited to patient-specific dispensing. Prior to implementation, pharmacy departments had to develop plans to switch their insulin orders to patient-specific while reducing the amount of ward stock vials as much as possible. Sites could choose to dispense patient-specific vials or pens, but most chose pens. Our diabetes educators strongly advocated for the switch to pen devices for improved continuity of care and increased opportunities for patient education, with the overall goal being improved patient safety. When it came to implementation provincially, we had to consider the logistics within pharmacy, such as inventory considerations as well as safety considerations around dispensing. We developed provincial recommendations for pen dispensing and labeling, and sites customized as needed to suit their local dispensing processes. We also consulted with our human factors team to develop auxiliary warning labels to address some of the infection prevention and control issues, like sharing of pens. We worked with our nursing colleagues as well as industry representatives to develop HS-specific training resources for insulin pens and safety needles. And this included webinars, newsletters, posters, and videos. All of these resources are housed on an internal insulin safety webpage that is used as a one-stop shop for diabetes management in AHS. A communication plan was also developed that utilized our clinical nurse educators to provide hands-on training and support for nursing staff throughout the local transition process. Overall, after implementing both of our safety strategies, we can reflect on what went well. As I mentioned earlier, the collaborative multidisciplinary approach allowed us to gain momentum on all of our diabetes-related initiatives. Early collaboration between teams ensured alignment between the formulary and provincial guidance documents, such as order sets or policies and procedures. As well, engaging a physician champion early on helped us facilitate the formulary consultation and, most importantly, garner support for final decisions. In addition, of course, staff were aware of the potential harm of insulin errors, and therefore they wanted to make it safer for patients. So the rationale behind the change seemed to make sense to staff. This made it much easier to get the frontline staff on board. And finally, we had good success with allowing sites to determine their own readiness and transition on their own timelines, using provincial resources and supports to guide them. However, as we all know, with every change of practice, there are also challenges. The streamlining of the formulary required therapeutic interchanges or automatic substitutions for non-formulary insulin products, which some clinicians did not agree with. Another one of our big challenges was related to the infection prevention and control risks of insulin pens that results from potential sharing of pens between patients, either intentionally or inadvertently. We used one pen, one patient as our communication tagline to raise awareness of this potential risk. As well, our staff experienced change management issues, particularly related to the technique required to use insulin pens and safety needles correctly. And in some cases, this resulted in patients not receiving the correct insulin doses. We also identified the need to follow up regularly to reinforce the proper technique, including the use of a competency checklist and ongoing training at staff education days. In areas that don't treat diabetic patients frequently, there are additional challenges with the device competency. Our webpage contains resources for staff that can quickly provide just-in-time training if needed. And in terms of process-related challenges, we fielded many questions related to cleaning and storage of insulin pens, as well as questions related to wastage and discharge planning, to name a few. We also faced and we continued to grapple with a number of challenges related to the evaluation of our initiative. We found it difficult to evaluate the effectiveness of the initiative, firstly because we had a lack of baseline data due to provincial variability in information systems and documentation. Another downside of our broad multidisciplinary approach meant that multiple initiatives were underway at the same time, which makes it difficult to isolate the effects from a single initiative. As well, we had wanted to evaluate end-user satisfaction with the transition to insulin pens, both with nursing staff and as patients, but we have not yet been able to capture this data provincially. Related to economics, we were interested in the product and device cost versus nursing time saved. While we do have some costing data which we are reviewing, we do not have nursing time studies to capture the nursing time saved. And related to medication error rates, we are currently in the process of combing through our recent data pull from our RLS system. We're looking for reduced rates of wrong patient, wrong drug, and wrong formulation, as well as increased accuracy in dosing. But we also recognize that this data may not give us the full picture. Because it is a voluntary reporting system, increased awareness may actually bias reporting and potentially increase the reporting rates. So what does our future hold? We plan to continue with ongoing follow-up on device competency, including monitoring our RLS reports of equipment failure and following up when needed with our manufacturers. When we complete the review of our data pull from RLS, we hope to identify the impact that we've had on our outcomes, as well as identify some other areas they may need attention. And in addition, we're looking at other ways to evaluate outcomes, such as performing a qualitative satisfaction survey with nursing staff and reviewing the impact of our inventory and procurement costs. And finally, we know that all of the work that's been done so far as a multidisciplinary group helps us to inform the new provincial clinical information system that will be coming to AHS over the next few years. Our standardization of clinical standards and processes helps to improve diabetes management for our inpatient population, and it's just one small piece of AHS's Connect Care initiative, which aims to improve the quality and safety of patient care overall. And that's the end of my presentation. Thank you.
Thank you for that detailed look at the steps that can be taken to optimize insulin safety in an acute care setting. It's so important to see what you've been able to do at your sites, and for those who might be thinking that they can try a few of these at their own site, I like that you've included some challenges that you've seen, so what they can anticipate and hopefully overcome before even starting. So we'll now actually get into the observatory for some quick med safety updates. So first up in the observatory is an update from the Canadian Institute for Health Information, or CIHI for short.
Thanks, Ambika. I want to congratulate ISMP for the excellent work on the Med Safety Exchange. I really feel and think that this marks a fundamental shift in how incident data is being used to support decision-making around patient safety initiatives in organizations. My name is Spencer Ross, and I'm the program lead at CIHI and work with a team on the National System for Incident Reporting. My tenure with the project has been long enough to see the project from pilot phase through to launch and growth. And at this point, the map shows where we collect incident data from. This is also a volunteer program like the Alberta system, and so organizations choose to be involved because they feel that there's a benefit in both personally and also to others by participating. Let's move on. Here we go. This presentation is brief, and many of you may be aware of what NSIR is, but before I show you a bit of data, I'm going to give a brief overview on what the National System for Incident Reporting is. The system was born out of the belief that incidents occur during the course of healthcare delivery, and that many of these incidents have common themes. This was always understood at the local level because people had been collecting this data for some time, but aggregating that data outside of a single facility had not been attempted at the time we were starting NSIR. So a national repository would enable sharing and, more importantly, learning from incidents beyond a single facility. That was the idea. And the intent was to build capacity at all levels, ultimately to improve patient safety. So how are the goals achieved? To do this, experts from across the country advised CIHI on the types of information that were important and formed the basis for the data standard or the common language with which we would share incident data. CIHI created a system with flexible options for data submission, both initially, I think, and importantly, with single data entry, but also later and currently now is batch upload of data from local or jurisdictional incident reporting systems. Importantly, users and participants are given access to the data and an analytical tool to create meaningful reports. So ultimately, the system is not intended to be a black hole the data disappears into. We want the data to be used for the purpose that it was intended. And so we see that there is data use at national, provincial, and local levels. At the national level, for example, ISMP Canada uses the data to support some of the bulletins that they produce on safe medication use. Health Canada has access to the data to fill their part of their mandate to examine issues related to manufacturer naming, labeling, and packaging. And at CIHI, we include an analytical section in the NSIR bulletin that is sent to registered users and is now available on CIHI's website. Provincial organizations such as Cancer Care Ontario or the Nova Scotia Health Authority, among others, have access to the data to conduct relevant analyses to support the safety initiatives that they undertake. And finally, and I think very importantly, submitters access their own data identifiably through NSIR, but they can also access de-identified data to support local safety work. Okay, so now the next few slides will just show a quick flavor of the data in NSIR and show how NSIR data can be used to explore aspects related to morphine and insulin to tie in with what was presented earlier. So what you see here is a typical top 10 list of the drugs that are reported to NSIR as being involved in incidents. And this list really hasn't changed a whole lot since we began, and certainly is reflective of what is happening in other jurisdictions around the world. A quick scan does reveal, as I said, the usual suspects, so nobody is usually surprised by this. Some of these drugs can be quite dangerous if used incorrectly, such as the opioids, insulin, and heparin. And acetaminophen is on the list too, and it's not usually as problematic if used incorrectly, but it is so ubiquitous that it means that incidents are more likely to occur. I think of interest, and I guess also not surprisingly, is that both presentations today were about drugs on this list, and I've highlighted them there. So let's take a little deeper dive into some of the data that NSIR holds on this. And really certainly not all of the data that NSIR holds on these issues, but they're a little bit of a focus to give people a flavor. So if we take a look at morphine to start, we find that there are over 1,700 incidents involving morphine reported in NSIR, and that about nearly 18% of them that are reported involve harm. So because I had enough detail about what today's presentation on morphine was, I was able to take a look at some of the IV pump issues that are talked about in the reports that we get. And I looked for cases in NSIR that had selected a contributing factor that related to infusion pumps and found 25. Exploration of these cases showed that wrong quantity or wrong rate were the predominant problems. And the text description seemed to point to programming issues related to concentration or rate. So that really actually supports what was presented earlier. So although providing a list of recommendations into NSIR data is optional, it is sometimes provided. And so I took a look at what is there as well. And here is just really a brief description of some of what I found. The detail is much greater in those fields when they are filled out typically. So improvement or addition to auxiliary pharmacy labels, after-hours narcotic supply processes, and education around a number of direct or related issues around morphine. And you can see the use of naloxone there as well. So that's a sample or a bit of a quick look at some of the data in NSIR that are related to morphine incidents. If we move on to insulin, again, starting off with about 47,000 medication incidents, approximately 3,000 of them within NSIR are have insulin as being part of the incident, and insulin of any type, not any one in particular. Interestingly, the percentage of harm is quite high, 26.7%, and certainly more than most other drugs and more than what we saw with morphine. And I think that that's a reminder that even though insulin is used very, very frequently and we become comfortable with it being in our settings, that it still has a very narrow safety range. And when we take a look at some of the problems that are reported, we see omitted dose, wrong quantity, and wrong product, and some of those things were discussed from the RLS system from Alberta. And also, we also see administration as the #1 process, but documentation, order documentation and preparing and dispensing are also key processes where errors or where incidents occur. And so this is my final slide. Similarly to the morphine case, here are some examples of the reported recommendations. Some are quite specific and others are more general in nature, as you can see. And I think that, again, the point is that people add this information, and depending on what it is that a user who's analyzing the data at the time is interested in looking at, they can review these to see if any of them apply or any of them could be considered in their own organization. I wanted to leave one thought before I hand it over to Ambika. We're all participating today with the hope of learning something, and the main idea of the Med Safety Exchange is that the experience of others, even when it comes from an error or an incident, is an excellent resource. And so I encourage you all to consider sharing your incidents with NSIR, with ISMP, or even locally if you're reporting. And if your organization currently participates in NSIR, I want to express my deepest gratitude for doing so. And if you'd like more information, please send an email to nsir@kaihai.ca, and we'll be pleased to respond to your questions. Thanks very much.
Great. Thank you, Spencer, for the CIHI update, and of course tying the med safety concerns that were brought up today regarding morphine and insulin. It aligned really well, and having that quantitative data supporting the qualitative findings from an individual incident. So we'll now have a CPSI update on their med safety initiatives.
From the Canadian Patient Safety Institute. I'm one of the co-leads for our medication safety portfolio. And again, I'd like to commend ISMP Canada on their continued excellence with this webinar series. For our presentation today, as I hope most of you knew, last week was the Canadian Patient Safety Week, so I'm just going to do a very brief recap of the week and remind you of a few initiatives, tools, and other resources that you might have missed that you can go back and look at your own leisure. So this year, we made it our mission to encourage patients and remind healthcare professionals what life-saving questions we should all ask about our medications. So the theme this year was Take with Questions, which was based on the online and free-to-download tool, 5 questions to ask about your medications. These questions, as a reminder, are have any medications been added, stopped, or changed, and why? Continuation, what medications do I need to keep taking and why? Proper use, how do I take my medications and for how long? Monitoring, how will I know if my medication is working and what side effects do I watch for? And follow-up, do I need any tests and when do I book my next visit? So for a full recap, please feel free to visit our website, asklistentalk.ca. This year we made, from a social media standpoint, a significant amount of impressions, almost 4.5 million impressions, 1,700 tweets, almost 800 participants, averaging close to 15 tweets an hour, as well as some tweets from many, many regional health authorities, provincial quality councils, and government representatives. One of the things we did this year as well was we launched 2 online quizzes. And we welcomed and challenged patients and healthcare providers essentially to test your medication safety knowledge and expertise with a real challenge to, can you reach the top tour of patient and provider excellence? So both these quizzes, if you didn't have the opportunity to do them or pass them on to friends, colleagues, and family members, they're both still open on our website. And we really encourage everyone to take the quiz and to continue having those conversations that are very, really just so critically important for ensuring medication safety. This year as well, we debuted a 3-part podcast series called Patient. And this is a very important series which is about people trying to change modern medicine and patient safety from the inside out. The current series, it's 3 episodes. They're all available at patientpodcastcanada.ca. And if you visit our CPSI website, you can redirect to the actual podcast as well. These episodes, in my opinion, really remind us of why we do what we do in patient safety and medication safety, and I'd really encourage everyone on the line to download and give a listen to these stories if you didn't have an opportunity to do so last week. They're very, very powerful. And just some stats on the impact that they had last week. It was the #2 medical podcast on all of iTunes during the week, and we had close to 1,000 downloads and close to 100 new subscribers. And CPSI, we are discussing internally, and we are considering maybe continuing the series moving forward. So if you haven't had the opportunity to check out those podcasts, I really encourage you to do so. And finally, last week, there was a national conversation that was held in Edmonton during the AHS Quality Summit Conference. And we had some fantastic commentary and insight from some well-known speakers in patient safety that included Dr. Ann Snowden, who's the chair of the World Health Innovation Network, Dr. Verna Yu, who's the president and CEO of Alberta Health Services, and Deb Prowse, who is the Alberta Health Advocate. The event was moderated by Ray Reset, who's the president and CEO of CCHL, and Chris Power, the CEO of CPSI. So the archive of the conversation is available on our website if you'd like to have a listen. Some of the topics included the importance of creating safe care environments, the urgency of implementing supply chain reforms, which I find is an emerging issue in medication safety and something that should be considered moving forward. Barcoding and tracking in order to prevent medication errors, and the role of senior leadership in supporting patient safety and the creation of safe care cultures. So to close, I'd like to, on behalf of CPSI, thank everyone, not only online for participating today, but for participating in Canadian Patient Safety Week. From what I saw and from what our communications team saw, there was a ton of engagement, some fantastic initiatives. So we really appreciate the support and your commitment to shining the spotlight on medication safety and patient safety more broadly. We always love to hear from our stakeholders, people throughout the country and throughout the healthcare system. So if you have any thoughts on Canadian Patient Safety Week or anything else related to our work, please feel free to reach out to us at any time. Thank you, and back to you, Ambika.
Great. Thank you, Steve, for the recap of the success of Canadian Patient Safety Week and those great initiatives. I've actually watched only the first episode so far of Patient, but it's very moving, especially when you hear directly from the patient and their family, the patient's family specifically. So we are getting close to the discussion time, and so I'd like to ask Dr. Mike Hamilton from ISMB Canada to give us a brief look at a selected med safety article.
Thank you, Ambika. This month, we decided to highlight a systematic review from Kim and colleagues out of Johns Hopkins in Baltimore. And this looked at how patient and family engagement strategies can be implemented, and really, do they have an impact on medication safety? The authors looked at 19 studies that included mainly older adults taking multiple medications, so certainly typical of what we might see in healthcare. Most of the studies reported on implementation measures, but 47% of them did report on medication errors, including both near misses and discrepancies. 37% of these reported on changes in patient and caregiver medication safety knowledge, and both of which I think are important in reducing error. They did rate most of the 19 studies to be medium to low quality. And the strategies that these interventions employed were typically centered around patient education and medication reconciliation. The education interventions were typically characterized as booklets, learning modules, or training programs. And the studies that focused on MedRec strategies used things like medication list cards, bringing medications to office visits, electronic medical records for feedback and communication, and also the involvement in the counseling of pharmacists and nurses. And among the 19 studies, 11 of them had control groups. And in the analysis, 55% of these reported statistically significant improvement on at least one of the medication safety outcomes, either related to medication errors or an increase in safety knowledge. As part of this systematic review, the authors adapted a model of patient and family engagement that may be worthy of further look. The ladder of patient and family engagement runs from simple one-way provision of information at the bottom all the way up to full integration of the patient and family in care. And although they hypothesized that the higher level patient engagement strategies may have greater improvements in medication safety, the researchers were unable to test this hypothesis really based on the studies being of medium to low quality, the paucity and heterogeneity of the data. However, in this review, they determined that most of the patient engagement strategies were generally of a low level. The authors suggest that interventions for patient engagement should not just inform sort of level 1 and 2, but should really incorporate higher levels of empowering patients, partnering them, and ultimately the goal of integration as full care team members. Certainly, I think further studies are needed to evaluate these associations, but I think this study is a good starting point. And it's really a reminder to all of us in healthcare to partner with patients in optimizing care and safety.
Great, thank you, Mike. And we appreciate all the great information shared today by our speakers. And we'll now turn our attention to the chat box and the Q&A that we've received throughout the webinar to keep the learning going.
So we'll do a couple questions for the first case related to morphine. So question number 1 is, does the redesigned pump not administer medication unless all checks are in place? Or is there some type of forcing function that you need to do the checks before the pump starts to function? And the second part of that question is, were frontline nurses involved in that redesign, and how are they accepting the changes?
Great question. With regards to forcing functions, so each time a clinical alert has been programmed into the pump, you must clear that clinical alert before it'll go forward to the next step. We do recognize, again, human factors being human factors, that sometimes clinical alerts can be bypassed by the user. Now, unfortunately, we weren't able to identify a way to limit the pump to run after an independent double check. So we do require independent double check documentation on MARS, IV flow sheets, and all the patient care records. We do an audit on those things as well as an audit of the pump itself programming. But we weren't able to identify how to make the pump do that forcing function. With regards to the second part of the question, yes, frontline staff were involved in both the initial drug library design as well as any updates. But what we recognized with this particular incident was that we had to add a frontline testing process. So anytime a request to change something on the pump is made, we have a group of individuals from each of our care areas, our critical care area, our general care area, our surgical care area, as well as our ED and OR. And we have frontline users from each of those care areas test what we are looking to update prior to having that change go into the live environment so that we can hopefully anticipate some of the failures that could possibly happen.
And second question, there have been a number of reports of other medications sort of running through based on misprogramming or what you described earlier, some type of workaround programming like the use of IV fluid settings to deliver medications. Is your organization looking at adopting what you've done for morphine to other medications that may run through at too higher rates like vancomycin, propofol, or other such medications?
Yes, we do utilize a couple of things. We utilize our electronic incident reporting system. So we do look for trends in errors involving IV pumps or errors involving associated medications. So much like the NSIR, we take a look at our top drugs to identify what some of the contributing factors are and looking at trending. We do have, sorry, part two of that question was?
Are you looking at other medications like vancomycin, propofol, other ones that might go through, or?
Right, so the second data source that we use is from our pump. So we are regularly looking at information with regards to our soft and hard limits to see where those limits are being reached, where they are being exceeded in terms of the soft limit, and where they're being reached in terms of the hard limit. And then going back to those particular medications and to the areas that are reaching those limits to see what practice issues are being encountered.
I'll now address the next few questions to the insulin case. And the first question would be, do you find that in your institution, the use of pre-filled disposable pens reduces medication errors enough to account for the cost of the pen?
Thanks. That's a very interesting question. And I think that, firstly, I think we all recognize the difficulty in assigning a value or a dollar figure to medication errors. So from our perspective, when we started that initiative, we set out at the beginning to be very clear that it wasn't that the implementation of pre-filled disposable pens was a safety initiative, and that we didn't want to assign or imply that it was going to be any cost-saving initiative in any way. And we were prepared for the potential, actually, of increasing our insulin costs overall, because, of course, we were coming from multi-dose vials, which would be, cheaper and being shared between patients. So I think that it's a hard question to answer in the financial sense, but I think that the benefits from the safety perspective, that we feel confident in using that, the pre-filled disposable pens has increased our patient safety for sure.
Second question is really sort of two parts, so I'll roll into one, related to things like risk and infection control. And one commenter in the audience suggested that some of these needles would pose risk to nurses as they aren't able to be removed via some sort of safety device or guard. And do you have any comments on that, or how could you address that? And part two of that question is, how are these insulin pens stored once used? Are they meeting infection control standards? Are they being brought into med rooms or whatnot?
So for the first question about the needles, in AHS, our policy for when nursing staff are administering an insulin dose using a pen device, they have to use an insulin pen safety needle, which prevents the risk of the needle stick injuries to our staff. So I think the question was referring to the regular pen needles. And if we have patients self-administering, they can use regular pen needles, but then they have to attach and remove the needle themselves and deposit them into the sharps container. But when staff are using the pens, they have to use the safety needle to prevent that risk. So hopefully that answered that question. And then the second part of the question related to storage, our policy in AHS is to use a disinfectant wipe to wipe down the pen prior to returning that pen to the medication room storage areas. And that would be the same advice that the same process that we would recommend for any multi-dose medication product that's taken to the bedside and then returned to the medication room.
Thanks, and I'll add a third question to your list. With a restricted formulary, or when you restrict the number of insulins available in the hospital, you'll likely need to invoke formulary changes often, and you've sort of alluded to this, but how do you handle these upon the discharge of the patient? Do they go back to their usual dosing at home, or is there some sort of mechanism that you make sure they understand what they're going home with if things have changed?
Yeah, that's a great question, and certainly one that's came up frequently during our transition. And so our perspective on that has always been that medication reconciliation on discharge is a very important part of that discharge process. And as we all know, in the inpatient setting, there's often numerous changes in medications, sometimes due to formulary, interchanges, but also just due to, change in medical status. And so it's really important to review with that patient on discharge so that they're clear about what medications they're supposed to be on when they go home. And our recommendation has always been that for that patient, if it's appropriate, for them to go back on the insulin product that they were on at home, if indeed that's suitable for what's happened to them from a medical perspective. So they can go back on what they are used to taking. And to that end as well, we don't allow our partially used insulin pens to be sent home with patients because we think that can contribute to confusion and possibly have the patient, double dosing or mixing up two different brands of insulin when they get home. So that's been our approach.
Thank you. And I'll address the next question towards our representative from CIHI. Spencer, in particular, could you please elaborate the kinds of incidents involving acetaminophen? Do you have a sense of what are some of the scenarios and root causes related to this?
Thanks for the question. I could probably do a better analysis if I had a few minutes to actually look at our data, but off the top of my head, I can give some feedback on that. We did a bulletin that we released in July that took a look at some of what we had on acetaminophen, but root cause analysis wasn't necessarily one of the things that we looked at. NSIR isn't good at capturing root cause analysis anyway. It's not really the database that does that. We do have some recommendations that are captured, and sometimes those are derived from root cause analysis that have been done. So there might be a little bit in there to inform on that. Really, root cause analysis is a strategy that is employed when an in-depth analysis is done, but not necessarily submitting the data. So just a little bit of disclaimer on that. But some of the data that we do have on acetaminophen, we know that it causes harm or it was reported to cause harm at probably a lower rate than overall that we get in NSIR, but still it is not without its risk, and 9% of the incidents that have been submitted to us have caused harm, whether or not it was a single ingredient, acetaminophen, or whether it was in combination with other products, typically codeine. Oh, but other opioids also can be in combination. When it's in combination, often the problem is that it's the wrong product that was selected. When it's singularly, the single ingredient, it's typically reported as an omitted dose problem. So those are some of the bits that we have in there about acetaminophen that I know off the top of my head. I'm more than happy to engage with anyone and do a more in-depth analysis should they contact us.
All right, so thank you for some really thoughtful questions this month, and I'll end off with one further question directed towards our morphine pump case. And how are you evaluating the implementation of the process, and how are you ensuring that the process really works, that people are using the proper settings, and are you continuing to audit the pumps related to morphine?
Great question. We do have an added benefit of having regular rotations of pharmacy students in our institution, so we are continuing to perform random audits on our nursing units utilizing our pharmacy students.
Okay, great. Thanks, Charlene. So that's going to conclude our discussion period. If we didn't get to any of your questions, if you could email it to me directly, I can pass it on to the individual speaker. So again, I do want to encourage everyone to be part of the Med Safety Exchange. So if you have an incident analysis or a Med Safety initiative, please email me to share the learning. And don't forget to fill out the poll that's available now on your screen, or we'll also send the questions in an email, whichever is more convenient for you, because we want your feedback. We want to make sure that the webinar is relevant to your needs. And just a reminder that the registration for next month's webinar on Wednesday, December 13th is now open, so you can head over to the website and register, because the next few weeks will fly by. So thank you again to all our speakers for the important analyses and strategies that were shared today, and to all our participants for joining the discussion and helping to share the learning. I hope you all have a wonderful rest of the day. Bye for now.